Welcome to this explainer. Today, we're looking at something that honestly feels a bit like magic, but it's actually deeply rooted in incredibly precise science. We're going to explore cranial radiography. Think of it as a total masterclass in invisible geometry. You know, when you or I look at an X-ray of a human skull, we just see the final product, right? But what we're uncovering today are the exact architectural blueprints required to get that perfect in it.
Okay, let's dive into this. Here is our playbook for today's explainer. We're going to cover 1. The geometry of the skull, 2. The reverse Caldwell view, 3. The lateral skull, 4. The Townes method, and 5. Evaluating the perfect shot. Let's get right into it.
Section 1. The geometry of the skull.
To truly get these protocols, you kind of have to realize that radiographers are essentially acting as architects. They're constantly aligning specific anatomical planes of the human body with their equipment to reveal what's hidden under the skin. Now, the absolute most important term in this whole architectural blueprint is the mid-sagittal plane, or MSP. This is that primary invisible line that divides the body exactly in half, left to right. In cranial imaging, perfectly aligning this mid-sagittal plane with the image receptor, or the IR, that is step number 1. I mean, this alignment is absolutely crucial before you even think about bringing radiation into play.
And hey, speaking of radiation, that brings us to the central ray, or CR. The central ray is the exact angle and focal point of the X-ray beam itself. Understanding exactly where and how this ray enters the skull, that is the key to mastering every single protocol we're going to look at today. Because it's not just about pointing a camera, it's about intersecting the skull's geometry with a highly precise beam of energy.
Section 2. Reverse Caldwell, frontal focus.
All right, so our primary goal here is to capture the frontal bone. We utilize a 10 by 12 vertical collimation, and we want to leave exactly a 1-inch border all around the skull. Setting this up requires an exact physical choreography, whether the patient is supine, lying on their back, or seated upright. First, you gotta center that mid-sagittal plane right to the image receptor. Then you flex the patient's neck so the orbital medial line, which is the line running from the outer eye to the ear canal, is perfectly perpendicular to the IR. Finally, you center the patient's nasion, the bridge of the nose, directly to the center of the IR. Plus, the shoulders have to be in the same horizontal plane, and both sides of the external acoustic meatus have to be equidistant to the receptor. I mean, we are talking incredibly precise stuff here.
And then comes the magic number, 15. See, for the reverse Caldwell, the central ray cannot just enter straight on. No way. It must be directed to enter the nasion at an angle of exactly 15 degrees cephalad. Cephalad just means angled upward toward the head. So why 15 degrees? Well, because this specific geometry intentionally projects the petrous pyramids, these dense ridges of bone inside the skull, down into the lower third of the orbits. That ensures you get a crystal clear view of the surrounding structures.
Once all this complex geometry is perfectly set up, the final instruction is blunt, but it is absolutely critical. Suspend respiration. Basically, hold your breath. Look, it doesn't matter how perfect your angles are if the patient moves. You do not want to blur the shot for sure.
Section 3. Lateral skull, the side view.
For this side view, we switch to a 10 by 12 transverse collimation. And interestingly enough, the nose and the mandible, they don't even need to be included. We just need that 1-inch border around the skull itself. Now, what's really fascinating about setting this up is a highly practical clinical detail, right from the source material about patient positioning. When setting up a seated or prone patient for a lateral view, there isn't actually an exact degree of body rotation required. But the text notes that on females, the breasts will actually help determine the degree of obliquity. The whole goal of angling the body here is to decrease the object-to-image distance, the OID, getting the skull as flush and as close to the image receptor as absolutely possible.
Once the body is positioned, the head has to be placed in a true lateral position. This involves a really fascinating contrast of lines. Check this out. Your mid-sagittal plane is now parallel to the IR. Your infraorbitomedial line is also parallel to the edge of the IR. But your interpupillary line, that's the line connecting the pupils of your eyes, must be perfectly perpendicular to the IR. It's like a giant, three-dimensional geometric puzzle.
Now, the central ray for a standard lateral shot is pretty straightforward. It's perpendicular, entering exactly 2 inches superior to the external acoustic meatus, or ear canal. But let's see how this setup shifts for trauma patients. If you have a trauma patient lying supine, you obviously can't just ask them to turn their head. Instead, you perform a cross-table lateral with a horizontal central ray. This specific trauma setup is incredibly important. Why? Because it's used to check for sphenoid sinus effusion, which can actually be a critical indicator of a basal skull fracture.
Section 4. Townes method, occipital focus. This method brings our focus entirely to the occipital bone at the back of the skull, and we return to our 10 by 12 vertical collimation. For the Townes method, the patient is either supine or upright. Their arms must be in the exact same horizontal plane to prevent any bodily rotation. You center the mid-sagittal plane perfectly to the middle of the IR. Then, the patient flexes their head forward enough so that the orbital medial line is entirely perpendicular to the image receptor.
But what if you have a patient who physically cannot flex their neck that far forward? Well, radiography has a brilliant workaround for this. If the orbital medial line is perpendicular, the central ray enters at a 30-degree caudad angle, meaning it's angled downward through the foramen magnum. But if the patient can't flex their neck, you simply ensure the infraorbital medial line is perpendicular instead and mathematically compensate by increasing the central ray angulation by 7 degrees. That brings it to a 37-degree caudad angle. It's just pure adaptable geometry.
Section 5. Evaluating the perfect shot. So you've aligned the planes, set the precise angles, and the image has been taken. Now how do you prove you flawlessly executed this invisible geometry? And this brilliantly illustrates the vastly different central ray angles we just explored. The reverse Caldwell shoots 15 degrees cephalade. The lateral skull comes in straight on, totally perpendicular. The Townes method shoots 30 to 37 degrees caudad. But remember, an angle is only as good as the final image.
So I've got a question for you. When you're looking at a complex, overlapping lateral X-ray of the skull, how can a radiographer objectively tell if the skull was slightly rotated or tilted?
The answer lies in this wonderfully punchy, essential rule of thumb used in the evaluation process. Vertical structures show rotation, while horizontal structures show tilt. It's that simple. If a vertical anatomical landmark is slightly off, the patient's head was rotated left or right. If a horizontal structure isn't perfectly aligned, the patient's head was tilted up or down.
For a lateral skull to be evaluated as perfectly successful, the magic word is superimposed. You must see perfectly superimposed orbital roofs and greater wings of the sphenoid. The left and right mastoid regions and external acoustic meatuses, perfectly overlaid. The left and right temporomandibular joints, your jaw joints, they must be superimposed. And beautifully, the sella turcica, which is the saddle-shaped depression in the skull base, must be perfectly in profile. If all these match up, your geometry was absolutely flawless.
Now, for the frontal reverse Caldwell and occipital Townes views, the evaluation relies entirely on perfect symmetry rather than superimposition. The image has to show equal distances from the lateral borders of the skull to the orbits or the foramen magnum. The petrous ridges must be perfectly symmetric. And hey, that mid-sagittal plane we started with, it must align precisely with the long axis of the collimated field. It's a really rigid test of spatial accuracy.
So, the crucial point is this. When a radiographer executes the Townes method perfectly, aiming that 30-degree caudad beam right through the top of the head, the resulting image creates a very specific, visually striking indicator of success. The dorsum sellae and the posterior clinoid processes, these are tiny, deep structures of the sphenoid bone. They will be perfectly framed and visible right inside the large opening at the base of the skull, the foramen magnum. You are literally threading the needle with radiation.
We've covered a whole lot of exact measurements, specific planes, and central ray angles today. Honestly, it's just incredible to think about the level of precision happening behind the scenes in a hospital every single day. So I'll leave you at this. Next time you look at a medical image, will you just see the bones, or will you see the invisible geometry that captured them? Thanks for joining me on this explainer, and I'll catch you on the next one.